Thank you for joining us today on the Anesthesia and Perioperative Medicine Channel. 本日は麻酔手術器医学チャンネルにご参加いただきありがとうございます。Merci pour votre excellent travail aujourd'hui lors de l'anesthésie d'un patient difficile pour une intervention chirurgicale complexe.
Right. Hello, everyone. Today, we are getting into the really crucial final part of the 2024 AHA/ACC guidelines on perioperative cardiovascular management. We're going to be tackling some of the trickiest clinical conundrums we face every day, fine-tuning those essential perioperative medications, navigating the absolute minefield of surgery after a PCI, and of course, how to react when you get that dreaded phone call about a postoperative troponin rise.
So here's our game plan. We'll kick off with a really detailed review of the latest recommendations on key perioperative drugs. From there, we'll dive headfirst into the very intricate world of timing and managing DAPT for our post-PCI patients, and we'll wrap up by unpacking the evaluation and management of postoperative myocardial injury, really teasing apart the differences from a full-blown MI, before we pull it all together with the key takeaways. Right then, let's get started.
Okay, let's jump straight into Part 1, Perioperative Medical Therapy. These guidelines have given us some much-needed clarity and, to be fair, a good bit of nuance on 4 classes of drugs that are just part of our daily bread and butter. We're going to go through each one in detail, looking at the top-line recommendations and, just as importantly, the evidence that's actually propping them up.
First up, statins. Now, we all know they're absolutely rock solid for long-term secondary prevention, but their exact role in that immediate perioperative window has always been a bit of a hot topic for debate. While the 2024 guidelines have come out with some very clear, very strong recommendations that I think really reframe how we should be approaching this.
Now, what's really striking here is just how strong these recommendations are. We've got 2 Class 1 or strong recommendations. First, for our patients who are already taking statins, the advice is simple. Continuation is recommended to reduce major adverse cardiovascular events, or MACE. That's a Class 1 recommendation based on non-randomized evidence. But second, and this is a really key practice point, for statin-naive patients who actually meet the criteria for long-term statin use, initiation is also recommended. This is also Class 1, but it's supported by randomized evidence. The message here is crystal clear. The intention is for the therapy to be continued long-term. It's about seeing the perioperative encounter as a golden opportunity to optimize a patient's lifelong cardiovascular health.
So what's the thinking behind all this? Well, the long-term benefits in preventing atherosclerotic cardiovascular disease are completely undisputed, right? They work by reducing LDL cholesterol and through their so-called pleiotropic effects, things like reducing inflammation and stabilizing plaques. We've got loads of observational studies suggesting that continuing them perioperatively is safe and seems to improve outcomes, especially in our high-risk vascular surgery patients. However, the evidence for starting a statin from scratch, a de novo initiation, just to prevent an immediate perioperative event is, well, it's a bit murky. The LOAD trial, which is the biggest RCT on this, found that starting a high-dose statin just before non-vascular surgery in patients who weren't on one before did not change the rate of MACE at 30 days. So, the crucial point is this. The guideline isn't suggesting we start a statin to prevent a heart attack in the next 24 hours. No, it's making a much bigger statement, that our preoperative assessment is the perfect time to identify patients who will benefit from a statin for the rest of their lives, and to actually get that vital therapy started.
All right, next up is the big one. The debate that has probably fueled more coffee room arguments than any other. What on earth do we do with RAS inhibitors? For years, practice has been all over the place, but these new guidelines are finally moving us away from a one-size-fits-all rule towards a much more nuanced, indication-specific strategy. And it's about time.
And this table from the guidelines just illustrates that new approach perfectly. You can see it separates the recommendation into 2 very distinct clinical scenarios that we see every single day. On one side, you've got patients taking RAS inhibitors just for hypertension, and on the other, you've got patients taking them as absolutely life-saving therapy for heart failure with reduced ejection fraction, or HFrEF. And as we're about to see, the advice for each is worlds apart. So let's break that down. For your standard patient with hypertension, the guideline gives a Class 2B, or a weak recommendation. It says that for select patients, and they mean those with well-controlled blood pressure who are heading for an elevated risk surgery, omitting the dose 24 hours beforehand may be beneficial to cut down on intraoperative hypertension. Just listen to how cautious that language is, may be beneficial. Now contrast that sharply with our HFrEF patients. Here we have a Class 2A, or a moderate recommendation that continuation is reasonable. The entire thinking is different. In HFrEF, these drugs are not just for blood pressure, they are a cornerstone, mortality-reducing, guideline-directed medical therapy. Stopping them, even for a single day, is a really serious decision that could potentially cause harm.
So let's dig into the evidence that led to these recommendations. The data we have consistently shows that continuing RAS inhibitors does, in fact, lead to more intraoperative hypotension. We see it on the monitor. But the multi-million-dollar question has always been, does that number on the screen translate to actual patient harm? And so far, the big randomized controlled trials have really failed to show that it does. The pre-op ACI study found that, yes, omitting the morning dose did reduce hypotension, but it had zero impact on MACE or how long patients stayed in hospital. More recently, the absolutely massive POISE-3 trial compared a hypotension avoidance strategy, holding ACE inhibitors and ARBs, to just carrying on as normal in nearly 7,500 patients. And what did they find? Absolutely no difference in their primary outcome of major vascular events at 30 days. The bottom line is, while we can make the blood pressure look a bit better on the monitor by holding the drug, we haven't been able to prove it actually helps the patient. And critically, these big trials pretty much excluded patients with severe heart failure. So for that group, the known life-saving benefits of the therapy far, far outweigh the unproven and theoretical risks of continuing it.
Okay, moving on to calcium channel blockers, or CCBs. And I have to say, compared to that very deep and detailed debate around RARS inhibitors, the guidance here is much more straightforward. This is mostly because the evidence base just isn't as big or as controversial.
The approach is really simple and pragmatic. First, there's just no evidence to support starting a CCB purely to improve perioperative outcomes, so that's not recommended. Second, for patients already on them long-term, it's considered reasonable to continue. And third, be vigilant. This is where our anesthetic knowledge really comes into play. We have to remember the distinct side effect profiles. The dihydropyridines, like amlodipine or nifedipine, they're peripheral vasodilators and are much more likely to cause or worsen hypotension. The non-dihydropyridines, on the other hand, like diltiazem and verapamil, have negative chronotropic and inotropic effects, so they carry a risk of bradycardia and myocardial depression. So basically, continuation is fine, but as anesthetists, we need to anticipate and be ready to manage these potential hemodynamic effects intraoperatively.
The last drug class in this section is the alpha-2 receptor agonists, with clonidine being the main one we come across. And on this topic, I have to say, the Guideline Committee leaves absolutely no room for doubt. The recommendation is as definitive as you can get.
This is a Class 3 no-benefit recommendation. It states, in no uncertain terms, that initiating low-dose clonidine perioperatively is not recommended to reduce cardiovascular risk. This is based on high-quality randomized evidence, level BR, and specifically from the landmark POISE-2 trial. This was a massive, brilliantly designed trial that not only showed no benefit from clonidine in preventing death or non-fatal MI, but it also raised some pretty significant safety concerns. Patients in the clonidine arm had higher rates of clinically significant hypotension and, most worryingly, a higher rate of non-fatal cardiac arrest. So the evidence has spoken, and the guideline is unequivocal. Do not start clonidine for cardioprotection. Case closed.
Okay, let's switch gears and move to our second major section. Now, this is without a doubt one of the highest stakes scenarios we have to manage, the patient with a prior percutaneous coronary intervention, or PCI, who now needs non-cardiac surgery. It is a very delicate and often quite stressful tightrope walk between thrombotic risk and bleeding risk. It requires a really deep understanding of the pathophysiology and, honestly, a truly collaborative team approach.
This is the million-dollar question we face almost every day in the preoperative clinic, isn't it? The stent itself creates this high-risk thrombotic surface, and then the surgery creates a high-risk bleeding state. The answer is incredibly complex and depends critically on the urgency of the surgery, the type of PCI they had, was it just balloon angioplasty, a bare metal stent, or a drug-eluting stent, and the clinical reason for that PCI in the first place. Was it for stable disease or an acute coronary syndrome? Thankfully, the new guidelines provide a fantastic algorithm to help us navigate this maze.
And here it is. This is Figure 5 from the guidelines, and it's basically our master guide. As you can see, it's a decision tree. The first big question is about the type of revascularization. Balloon angioplasty only, a bare metal stent, or BMS, or a drug-eluting stent, a DES. If it's a DES, the algorithm then splits again based on the indication. Was it for an acute coronary syndrome, an ACS, or for chronic coronary disease, CCD? Each path leads to a different recommended waiting period. So let's break this down piece by piece.
Let's start with purely elective non-cardiac surgery where we actually have the luxury of time. This timeline really just distills the key minimum waiting periods. After a simple balloon angioplasty with no stent, you need a minimum of 14 days to allow the vessel endothelium to heal. After a bare metal stent, which endothelializes relatively quickly, that period extends to 30 days.
For a modern drug-eluting stent that's been put in for stable chronic disease, the ideal delay is 6 months. This allows for almost complete endothelialization under the cover of dual antiplatelet therapy. And finally, for our highest risk group, a DES placed in the inflamed, prothrombotic environment of an acute coronary syndrome, the recommendation is to wait a full 12 months. All of these timelines are designed to get the patient past that window of highest risk for a catastrophic stent thrombosis.
Now this is where we really see the layers of nuance in the guidelines. Waiting 14 days after angioplasty and 30 days after a BMS are both strong Class 1 recommendations. Waiting 12 months after an ACS is also Class 1. Waiting 6 months after a DES for stable disease is a slightly less forceful Class 2A recommendation, but the guidelines also acknowledge time-sensitive surgery. Think of a cancer diagnosis where a delay could actually worsen the prognosis. In these specific cases, for a DES patient, proceeding after 3 months may be considered, but this is a weaker Class 2B recommendation, reflecting that incredibly delicate risk-benefit calculation. Now please everyone, draw your attention to that final column. This is the crucial, unmissable safety warning. Performing non-cardiac surgery within 1 month of placing a drug-eluting stent is a Class 3 harm recommendation. This isn't a suggestion, it's a hard stop. In this period, the risk of a fatal stent thrombosis, if you withdraw DAPT, is simply unacceptably high.
I think a huge takeaway here is the absolute necessity for a multidisciplinary discussion. This is never a decision for one person to make in a silo. It absolutely demands a meeting of minds between cardiology, surgery, and anesthesiology. We have to weigh the patient's individual thrombotic risk, was it a complex bifurcation stent for an ACS, against the specific bleeding risk of the planned operation. A really crucial point, which is heavily emphasized, is that aspirin should be continued whenever it is surgically feasible. Stopping aspirin is a significant independent risk factor for stent thrombosis. Even if the P2Y2 inhibitor, like clopidogrel, has to be stopped, just keeping that aspirin going provides a critical layer of protection. And the guidelines really hammer home that the first 3 months after any PCI represent the period of highest vulnerability, and all but the most urgent, life-or-limb surgery should be avoided.
And that brings us to our final section. What to do when, despite all of our best efforts, a cardiac complication happens postoperatively. This part of the guideline focuses on the systematic evaluation and management of an elevated postoperative troponin, which is a really common and often confusing clinical problem that demands a precise, logical diagnostic approach.
This is the call that none of us wants to get, but I'm afraid all of us will at some point. The labs have flagged a high-sensitivity troponin on your day 1 postoperative patient. This single number sets off a really complex and urgent diagnostic cascade. So what do you do first? How do you separate the signal from the noise and work out what it actually means?
Well, the guidelines provide a really clear stepwise algorithm. First, always go back to basics. Assess the patient. Are they having chest pain, shortness of breath, or new hemodynamic instability? Remember, symptoms are so often masked by our analgesia. Second, get a 12-lead ECG immediately. This is your first major branch point. Do you see ST segment elevation? If you do, your diagnosis is a postoperative STEMI. This is an emergency, and there's a Class 1 recommendation to manage it with guideline-directed medical therapy and consider urgent coronary angiography. If there's no ST elevation, your job gets a bit more complicated. You have to figure out if the troponin rise meets the universal definition for a non-ST elevation MI, or NSTEMI, which requires some evidence of ischemia, or if it represents what we now call postoperative myocardial injury. And if it is an NSTEMI, you then have to differentiate between a type 1 event from plaque rupture and a type 2 event from a supply-demand mismatch.
Let's be very precise about this term, MINS, or myocardial injury after non-cardiac surgery. This is a critical diagnosis to get your head around. MINS is defined as an elevated postoperative cardiac troponin of presumed ischemic origin. But, and this is the key bit, the other criteria for an acute MI are not met. This usually means there are no new ischemic symptoms or significant ECG changes. It's essentially an isolated troponin rise. It can be really tempting to just dismiss this as troponitis, but that would be a huge mistake. MINS is independently associated with a staggering 30-day mortality of around 10%. It is a powerful, often silent predictor of poor short and long-term outcomes. This is not a benign finding.
This table really helps to clarify these key differences. A type 1 NSTEMI is your classic heart attack. An atherosclerotic plaque ruptures, a thrombus forms, and the vessel gets blocked. It's a plumbing problem. A type 2 NSTEMI is caused by a supply-demand mismatch in the presence of stable coronary disease. Think severe anemia, tachyarrhythmia, or prolonged hypotension. It's a logistics problem.
Both type 1 and type 2 NSTEMIs, by definition, must have associated ischemic evidence, like chest pain or new ECG changes. MINS is the outlier. It's a troponin rise that we believe is ischemic in origin, but it lacks those overt clinical or ECG signs, and this is what makes it so insidious. Management is also different. Type 1 focuses on antiplatelets and angiography. Type 2 focuses on fixing the underlying problem, like transfusing the patient, and MINS focuses on initiating long-term risk factor mitigation and considering GDMT, like statins and aspirin, for secondary prevention.
So what is our role as anesthetists in all of this? Well, our role is absolutely pivotal, and it spans the entire perioperative journey. First and foremost is prevention. Tight hemodynamic control, avoiding prolonged hypotension and tachycardia, and optimizing oxygen delivery to the heart muscle. Second is monitoring, using our clinical judgment and risk stratification tools to identify which high-risk patient should have postoperative troponins checked in the first place, because routine screening of everyone isn't recommended. Third is early detection. We have to maintain a really high index of suspicion because our anesthesias and potent painkillers will often hide the classic anginal symptoms. And finally, collaboration. The moment we detect an injury, we must initiate prompt and clear communication with our medical and cardiology colleagues to formulate a joint management plan and ensure proper follow-up.
And that brings us to the end of this deep dive. Throughout all of this, a recurring theme has been the absolute necessity of a team-based, multidisciplinary approach, whether it's for deciding on DAPT interruption or managing a postoperative MI. This kind of medicine simply cannot be practiced in silos. So I'll leave you with this question to take back to your own practice. In your hospital, what is the single biggest barrier to that effective, timely communication between surgery, cardiology, and anesthesiology? And what's one small thing you could do tomorrow to help break it down? Thank you so much for your time.